Every day, families hear a sentence that changes the rest of their lives. Your memory changes may be dementia. And once that word enters the room, everything starts to feel final. The forgotten appointment, the lost keys, the missed turn on a familiar road, the blank moment in the middle of a sentence. Everyone looks at the older person they love and quietly thinks the same thing. Maybe this is just aging. But before you accept that explanation, I want you to open one place in the house that almost nobody connects to memory loss. Not the brain scan, not the family history, the medicine cabinet. Because for some older adults, the problem is not simply age, it may be a medication. Or even more often, it may be several medications quietly pulling on the brain at the same time. I'm Dr. William, and in years of working with older adults, I have seen this story over and over again. A person who used to be sharp starts moving through the day in a fog. Their family says they repeat themselves, they forget conversations, they look less steady, they sleep more, they seem less present. And because the person is older, everybody accepts the easiest explanation. This must be dementia starting. Sometimes it is. Dementia is real and it deserves a serious medical evaluation. But sometimes memory loss is not the beginning of an irreversible disease. Sometimes it is a warning signal from a medication list that no one has reviewed carefully enough. So today, I'm going to walk you through 9 medication categories that deserve a careful memory review, especially after age 65. I am not telling you to stop anything on your own. That would be dangerous. Some of these medications must be tapered slowly. Some protect your heart, your mood, your sleep, your bladder, or your safety. The point is not fear. The point is to ask better questions before memory loss is blamed on age alone. Stay with me until number 1, because the most dangerous item on this list is not one single pill. It is the combination almost nobody counts. Number 9 is diphenhydramine and the nighttime allergy pills hiding in plain sight. You may know diphenhydramine from allergy products, cold medicines, or the little PM sleep aids people take when they cannot fall asleep. Doxylamine is another common nighttime ingredient in the same general concern group. These pills are easy to trust because they are sold over the counter. No appointment, no prescription, no warning conversation, just a bottle on the shelf that promises relief from sneezing, itching, congestion, or sleeplessness. But in an older brain, these medicines can act very differently than people expect. Diphenhydramine is a first-generation antihistamine with strong anticholinergic effects. That means it can block acetylcholine, a chemical your brain uses for attention, learning, and memory formation. Think of acetylcholine as one of the messengers that helps your brain write down what just happened. Where did I put my glasses? What did my daughter just tell me? Why did I walk into this room? In younger adults, one occasional dose may simply cause drowsiness. But in older adults, especially with repeated use, the same medicine can contribute to confusion, dry mouth, constipation, urinary problems, blurred vision, dizziness, and falls. The American Geriatric Society, Beer's criteria, lists first-generation antihistamines such as diphenhydramine and doxylamine as medications older adults should generally avoid because of anticholinergic effects and risks such as confusion and falls. The mistake is assuming that over-the-counter means gentle. It does not. Some of the strongest brain-clouding medicines in an older adult's home may not come from a prescription bottle at all. They may come from the sleep section of the pharmacy. Here is what I want you to do tonight. Look at anything you take for sleep, allergies, colds, or anything labeled PM, nighttime, or sleep aid. Read the active ingredients. If you see diphenhydramine or doxylamine and you use it often, do not panic and do not suddenly replace everything by yourself. Bring the bottle to your doctor or pharmacist and ask, is this safe for my memory and fall risk at my age? For allergies, many people can use newer antihistamines that are less sedating, but the right choice depends on your health history. The point is simple: do not let a drugstore shelf make medical decisions for your brain. Number 8 is the stomach medicine people forget to review. proton pump inhibitors, or PPIs. These include omeprazole, esomeprazole, pantoprazole, lansoprazole, and similar medications. They can be very helpful. If you have severe reflux, ulcers, bleeding risk, Barrett's esophagus, or certain high-risk conditions, a PPI may be exactly what you need. But many people start one for heartburn and stay on it for years without anyone asking whether the original reason still applies. That is where the concern begins. Your stomach acid is not only there to annoy you, it helps your body absorb certain nutrients. Long-term acid suppression can contribute in some people to low vitamin B12, low magnesium, and other issues that can affect nerves, energy, balance, and thinking. Low B12 can look frightening. It can cause numbness, weakness, walking problems, confusion, depression-like symptoms, and memory complaints. A family may see the memory problem first and never suspect the stomach pill. This does not mean PPIs are dementia pills. That would be too simple and too alarmist. The research on PPIs and dementia risk has been mixed, and many people need these medicines for good reasons. But long-term daily use should not run on autopilot. The question is not, is this medicine bad? The question is, do I still need this medicine at this dose every single day? Ask your clinician, why did I start this? Do I still need it? Can we use the lowest effective dose? Should we check vitamin B12 or magnesium? Is step-down therapy possible? Are there lifestyle changes that could reduce my need? Do not stop a PPI suddenly without guidance, because reflux can rebound and some conditions require protection. But do not leave it untouched for a decade just because it became part of your morning routine. Number 7 is bladder medication, especially oxybutynin and other antimuscarinic drugs for overactive bladder. I want to handle this one with respect because bladder urgency is not a small problem. It can control a person's whole day. It can make someone afraid to leave the house. It can disturb sleep, cause embarrassment, and increase fall risk when someone rushes to the bathroom at night. Relief matters, but oxybutynin works by blocking muscarinic receptors, and that anticholinergic action can affect the brain. In older adults, it may contribute to dry mouth, constipation, blurred vision, dizziness, confusion, and memory trouble. The Beers criteria notes that oxybutynin has some of the strongest evidence for adverse cognitive effects among bladder antimuscarinic medications, while still advising caution with the whole class. Here is what bothers me most. Many patients are warned about dry mouth. Fewer are warned clearly about possible thinking changes. So when an older person starts a bladder pill and becomes foggier, slower, or more forgetful, the symptom may be blamed on aging instead of being reviewed as a possible medication effect. Families say, "Mom is just declining," but sometimes the timeline tells a different story. The fog started after the medicine. The confusion worsened when the dose increased. The falls began after nighttime bathroom trips became mixed with sedation and dizziness. If you or someone you love takes oxybutynin and memory has changed, ask for a review. Do not stop on your own. Ask whether the dose is still appropriate, whether non-drug bladder strategies could help, and whether alternatives such as mirabegron or other options might fit your case. You should not have to choose between your bladder and your brain without a careful conversation. Number 6 is statins, and this one requires the most balanced explanation. Statins include atorvastatin, simvastatin, rosuvastatin, pravastatin, and others. They lower LDL cholesterol and can reduce the risk of heart attack and stroke in people who need them. For many patients, statins are protective and important. I am not here to scare people away from a medication that may be protecting their heart or brain from vascular disease, but I also do not want people to ignore timing. Statin labels include rare post-marketing reports of cognitive problems such as memory loss, forgetfulness, amnesia, memory impairment, and confusion. These reports are generally described as non-serious and reversible after stopping the statin, but they are rare and do not prove that statins commonly cause dementia. In fact, broader studies often do not show meaningful cognitive harm from statins, and preventing strokes may protect cognition. So what do you do with that complicated truth? You do not stop the statin because a video made you nervous. A heart attack or stroke can change your life in a way no internet warning should risk. But if you started a statin, changed the dose, or switched to a different statin and then noticed new brain fog, new confusion, word-finding problems, or memory changes, tell your clinician. Ask whether the timing matters. Ask whether other causes should be checked, such as thyroid problems, B12 deficiency, sleep apnea, depression, alcohol, infection, dehydration, or medication interactions. Ask whether a dose adjustment or a different statin is reasonable. The message here is not anti-statin. The message is pro-review. Your heart matters. Your brain matters. A good doctor should care about both. Number 5 is benzodiazepines, including alprazolam, lorazepam, diazepam, clonazepam, temazepam, and similar medications. These drugs can feel like rescue. Panic slows down, muscles relax, sleep finally arrives. For short-term use in the right situation, they can be helpful. But in older adults, they can also create real danger. Benzodiazepines can impair memory, slow reaction time, increase confusion, worsen balance, and raise the risk of falls and fractures. Long-acting versions can build up in the body. Short-acting versions are not automatically safe either. The Beers criteria recommends avoiding benzodiazepines in many older adults because they increase risks such as cognitive impairment, delirium, falls, fractures, and motor vehicle crashes. Many families recognize the sedation but do not connect it to memory. They say, "Dad is calmer now," but they also notice he is less engaged. Mom sleeps better, but now she is unsteady in the morning. He does not panic as much, but he repeats questions more often. Sometimes the medicine is still necessary, sometimes it is not. But the biggest warning is this: if you have been taking a benzodiazepine regularly, do not stop suddenly. Abrupt withdrawal can be dangerous. It can cause severe anxiety, insomnia, agitation, tremors, seizures, and serious medical complications. The right conversation is a supervised taper, sometimes over weeks or months, depending on the person. Ask your doctor what the original goal was. Ask whether the medication is still needed. Ask whether safer long-term strategies exist. For anxiety, some people may benefit from therapy, buspirone, certain antidepressants, breathing training, or other approaches. For sleep, cognitive behavioral therapy for insomnia can be powerful without sedating the brain. The point is not to suffer. The point is to stop using chemical sedation as a permanent solution without regular review. Number 4 is amitriptyline and related older tricyclic antidepressants. Amitriptyline is an interesting medication because many people taking it do not think of it as an antidepressant. They may take it for nerve pain, migraine prevention, sleep, fibromyalgia-type pain, or chronic pain. The dose may be small. The pill may be taken only at night. It may have been started years ago. That is exactly why it can hide. Amitriptyline has strong anticholinergic effects. It can cause sedation, dry mouth, constipation, urinary retention, dizziness, blurred vision, and cognitive fog. In an older adult, especially when combined with other anticholinergic medications, it can make thinking slower and memory less reliable. A person may struggle to find words. They may feel heavy in the morning. They may not connect the problem to the tiny pill they take before bed because it was prescribed for pain, not for mood. Here is the key question: is the medicine still earning its place? If amitriptyline dramatically improves nerve pain and nothing else works, that is one conversation. If it was started years ago for sleep and nobody has reviewed it since, that is another. Do not stop it abruptly without guidance, especially if you have been taking it regularly. Ask your clinician whether the benefit still outweighs the burden. For nerve pain, there may be alternatives or non-drug strategies. For sleep, there may be safer long-term approaches. For mood, Newer antidepressants may be a better fit for some patients. The important thing is to recognize that a medicine prescribed for pain can still affect memory. Your brain does not care which specialist wrote the prescription, it feels the total chemical load. Number 3 is paroxetine, often sold under the brand name Paxil. This one surprises people because paroxetine belongs to the SSRI family, and SSRIs are often thought of as newer, cleaner, and gentler than older antidepressants. But paroxetine stands out because it has meaningful anticholinergic activity compared with many other SSRIs. The Beers criteria lists paroxetine among antidepressants with strong anticholinergic activity and recommends avoiding it in many older adults when possible. That does not mean paroxetine is never appropriate. Some people have taken it for years and done well. Some people may have tried other treatments without success, and stopping suddenly can cause withdrawal symptoms or a return of anxiety or depression. But in an older adult with new memory concerns, confusion, sedation, falls, constipation, or other anticholinergic side effects, paroxetine deserves a serious review. The painful irony is that a medication prescribed to help the mind can sometimes cloud the very clarity a person is trying to protect. If you take paroxetine, do not panic. Do not stop it tonight. Instead, ask your doctor, at my age, is this still the best antidepressant for me? Is the anticholinergic effect a concern? Would another SSRI such as sertraline or escitalopram be safer in my situation? How would we taper if we ever changed it? Those questions matter because antidepressant changes need planning. The safest move is not sudden action. The safest move is informed review. Number 2 is antipsychotic medication used in older adults, especially when used for sleep, agitation, or behavioral symptoms without a clear plan. This category includes quetiapine, risperidone, olanzapine, haloperidol, and others. These medications can be necessary for serious psychiatric conditions such as schizophrenia, bipolar disorder, psychosis, or dangerous agitation, but they are powerful drugs, not casual sleep aids. In older adults with dementia, antipsychotics carry serious warnings, including increased risk of stroke and death. They can also cause sedation, movement problems, falls, metabolic changes, and worsening cognitive slowing in some people. What worries me is when families are told this will help them sleep or this will calm them down without a full discussion of the trade-offs. Sometimes the person becomes easier to manage because they are more sedated, but easier is not always better. A family may say, she is quieter now, but she is also less present. He is not yelling anymore, but he is barely participating. Sometimes the disease is progressing. Sometimes medication effects are adding to the decline. If an antipsychotic is truly needed, the questions should be specific. What symptom are we treating? Is the person dangerous to themselves or others? Have pain, constipation, infection, dehydration, sleep disruption, hearing problems, vision problems, and overstimulation been addressed? What non-drug strategies were tried? What is the lowest effective dose? How long will we continue it? When will we reassess? In dementia care, routines, lighting, hearing aids, glasses, hydration, pain control, bowel care, reducing noise, and improving sleep timing can sometimes reduce agitation without immediately escalating medication. Not always, but often enough to ask. These drugs may have a place, but they should not quietly become permanent without review. And now, number 1, the biggest hidden threat is not one medication. It is anticholinergic burden and medication stacking. This is the part almost nobody talks about at the pharmacy counter. A person may not be taking one obviously dangerous pill. They may be taking several ordinary ones, a diphenhydramine sleep aid at night, oxybutynin for bladder control, amitriptyline for nerve pain, paroxetine for anxiety, maybe a nausea medicine or muscle relaxer added later. Each one alone may seem explainable. Each one may have been prescribed by a different person. one came from the drugstore, one came from primary care, one came from urology, one came from psychiatry, one came from urgent care. The patient assumes somebody is adding it all up. Very often, nobody is. Anticholinergic burden means the combined effect of all medications that block acetylcholine or act in similar brain clouding ways. The Beers criteria warns that cumulative exposure to anticholinergic drugs is associated with increased risk of falls, delirium, and dementia, and that clinicians should consider total anticholinergic burden during regular medication reviews. This is the real villain in many medication-related memory stories. Not the one pill with a scary name, but the slow stacking of several familiar pills with familiar labels. The brain does not experience them as separate prescriptions. The brain experiences the total load, and that total load can look like aging. It can look like early dementia. It can look like depression. It can look like a person simply slowing down. Here is the hopeful part. Medication-related cognitive fog can sometimes improve when the burden is reduced early enough. Not always. Not every memory problem is medication-related, but some are, and that possibility is too important to ignore. The solution does not require a miracle. It requires a medication review. Put every bottle on the table. Prescription drugs, over-the-counter products, sleep aids, allergy pills, cold medicines, bladder pills, pain medicines, mood medicines, nausea medicines, muscle relaxers, supplements, eye drops if relevant, patches, creams, everything. Then ask your doctor or pharmacist one direct question: what is my total anticholinergic burden, and could any of these be contributing to memory problems, dizziness, constipation, confusion, sleepiness, or falls? That question may be one of the most powerful questions an older adult can ask. Now let me give you the action plan I wish every family had before panic sets in. First, do not stop medications on your own. This is especially important for benzodiazepines, antidepressants, antipsychotics, heart medicines, seizure medicines, blood pressure medicines, and anything you have taken for a long time. Sudden stopping can be dangerous. Second, make a complete list. Include the drug name, dose, how often you take it, who prescribed it, and why you started it. Third, include over-the-counter products. Many memory-clouding medicines never appear on the official prescription list because the patient buys them without telling anyone. Fourth, write down the timeline. When did the memory change begin? What medication was started before that? What dose changed? What was added after a hospital stay, urgent care visit, surgery, fall, infection, or sleep crisis? Fifth, ask for a formal medication review with a pharmacist or clinician who is comfortable caring for older adults. Sixth, ask which medicines are still necessary, which can be reduced, which can be replaced, and which require slow tapering. Seventh, if memory changes are sudden, severe, or rapidly worsening, do not assume medication is the only cause. Get a full medical evaluation. Memory problems can also come from infections, thyroid disease, low B12, depression, grief, sleep apnea, dehydration, alcohol, hearing loss, vision problems, pain, and many other treatable causes. A good evaluation looks wider than one explanation. Before you go, I want you to do something practical. In the comments, write your age and the number of medicines you take every day, including over-the-counter sleep or allergy pills. You do not have to share private details, just the number. 3, 5, 8, more than 10? That number matters because the risk often rises when medications accumulate quietly. And if you care for an older parent, open the medicine cabinet tonight. Look for PM sleep aids, allergy pills, bladder medications, older antidepressants, paroxetine, benzodiazepines, antipsychotics, and long-term stomach acid medicines. Do not throw them away. Do not panic. Write them down. Bring the list to a professional and ask for a review. The goal is not to fear medication. Medication saves lives. The goal is to stop treating every prescription as permanent and every memory problem as inevitable. Sometimes the brain is not failing, sometimes it is being chemically slowed, and if you catch that early, the path forward may be very different. I'm Dr. William. Stay alert, ask better questions, and I'll see you in the next video.